And recent findings are very important, and I think what it's really important is this is a rapidly moving field. And what is also nice is that in cardiovascular field, we can learn from other areas. So it's a rapid moving field in all areas of disease. And that's why it's important to follow the field and pick up things from other areas, from cancer, from pulmonary disease to several different areas, and find out what can be applicable to cardiovascular disease. And just as an example, there's new findings in immunology that can be translated from one disease into cardiovascular disease and its potential effects, but also direct effects on structural cells and how this can actually affect important pathophysiological processes. One example is, for example, fibrosis, which is something which can be found in several diseases, and then picking up the different advancement can be of real importance for specific findings, putting that forward in cardiovascular disease. So new treatments are important in cardiovascular disease, or actually as in every disease, but we are very relying on lipid-lowering therapy, antiplatelet therapy, risk factor controlling medications, and what is emerging is anti-inflammatory treatment, and we are coming closer to having that as yet another class of medications in cardiovascular prevention. But there's some drawback with anti-inflammatory treatments, and that is the risk of immunosuppression, which limits its implications also and the implementation in long-term treatment as cardiovascular prevention. I think that's where the pro-resolving mediators and the whole concept of the resolution of inflammation plays a very important role in cardiovascular prevention. To target the inflammatory reaction when we don't need it, but retain it when we need it. And it's a long-term treatment of cardiovascular disease. It's known to us in the field that it is an inflammatory disease, but maybe not always considered among the classical inflammatory diseases to motivate an anti-inflammatory treatment. And this potential of having an immunomodulation, which is beneficial for the chronic inflammation associated with the cardiovascular system, but still retaining an immune function to avoid the potential side effects of immunosuppression with an anti-inflammatory treatment. I think this is what really distinguishes this field from the general anti-inflammatory field, which is indeed a very important field in cardiovascular, new classes of cardiovascular prevention. You're raising a very important point. So the prototype of the notion of the resolution of inflammation is really the acute inflammation and its resolution. Now, when we talk about cardiovascular disease, it is indeed a mix of chronic inflammation and acute inflammation. There are situations of acute inflammation in cardiovascular disease. For example, the acute cardiovascular event is associated with an acute inflammatory response. And also interventions, for example, surgery. But then we also have this chronic inflammation, which is ongoing, low-grade chronic systemic inflammation, which is a typical hallmark of the atherosclerotic inflammation. So how to resolve this? Is it a chronic stimulation that goes on? It is still varying over time. So it's fluctuations, and the importance of being able to resolve and to actually cope with the pro-inflammatory environment. And the key point is this, that the chronic inflammation can also be triggered into an acutization of the chronic inflammation. And this is what distinguishes, for example, the unstable atherosclerotic plaque, which is just about to rupture and potentially cause the event. So to be there, to be ready for the resolution when it is needed will be really key in this role of the resolution in atherosclerotic cardiovascular disease. So we come to a point of really an impending doom. The inflammation will increase, and if we can resolve the inflammation before the plaque rupture, that would actually prevent the event. So that's how the concept that the inflammation in cardiovascular disease has both the chronic and the acute components, and that the resolution concept can be applied to both concepts. So then we come to the next challenge in this area. It's how to get the pro-resolving response on site by stimulating, how to really get these mediators at the right point. And there are several different possibilities here to do that, to have an administration at the time of intervention, to really have a local administration, or to be able to administer these mediators in formulations that can actually find their targets. So particles that can specifically locate and release at the site of the atherosclerotic plaque. And another possibility, because there are several possibilities in this, is that we will provide everything so the whole machinery for local production is ready. So when it is needed, they can be produced on site. But this is indeed part of the challenges in this field, to get the pro-resolving mediators to the right place and at the right time. There are several different ways to get to this, and at every level it is important. So it is important to preserve health, to take that in consideration when controlling risk factors, and also even when disease is established, to be able to treat disease. So it's both has a role in prevention and treatment, and when it comes to prevention, both the primary prevention and the secondary prevention. And there are several different things in this to really pinpoint out. And in this context, it's also the fact that it may not be the same thing for everyone. So we're going towards personalized medicine. And in this sense, it's also very important that the resolution response can be personalized also, so that we need to also find, in a case of a failure in the resolution of inflammation, how can this be solved for specifically under certain circumstances. And we also see changes in lifestyle. For example, vegan diet that will limit the intake of fish oils, the source of omega-3 fatty acids, EPA and DHA, as direct substrates for the formation of resolvins, for example. And that's why it's very important to also understand different ways of facilitating this endogenous production, and what counseling to give depending on different factors. So that's why the personalization is not only towards personalized medicine, but even towards personalized prevention. So aortic valve stenosis is a particular in cardiovascular disease, because as of today, we don't have any specific medical treatment. So we rely on surgical and interventional cardiology to treat the valve disease when it comes to end stage and needs to be. So the valve is diseased and needs to be changed, or with the implantation of a new valve by catheter. So the need for a medical treatment is there. That's what makes it particularly challenging, but also very important to explore this. And this is one of the focus areas that we have been looking into, and really been able to see that indeed the inflammatory response locally within an aortic valve is a failure in the resolution of inflammation, and experimentally we have been able to show also that lacking receptors for pro-resolving mediators will exacerbate the disease. And now to take this further, to really put this into a treatment context, it's where we are standing right now. But with promising experimental results, then this is the one possible way to go. But it's also a field which needs to advance on all different levels. But this is one potential way to go to get to the key pathophysiologically important reactions in the aortic valve. So again, the main challenge is we need to induce the resolution of inflammation at the right site, at the right time, and for the right person. So the challenges, there are plenty of challenges in this field, but we also have plenty of opportunities in this. So we have tools available, omega-3 supplementation, for example, and one of the ways to go is to optimize the omega-3 supplementation, both in what substance to use, in what formulation, in what doses, in what composition of different fatty acids, for example, and this may, to a large extent, be personalized. So there are possibilities, but then also how do we find the responders and non-responders to treatment, and how can we adjust the treatment to the non-responders to make them into responders? So again, personalized medicine is coming and will be, and the field of omega-3 supplementation and the stimulation towards the metabolism into specific pro-resolving mediators is a challenge, but it is a possibility. So we have for a long time been interested in inflammation behind cardiovascular disease and how to target it. And our research has focused a lot on the actual effects of the individual pro-resolving mediators when they activate their receptors. And one of the things that we have found is that the specific receptors are not completely uniformly distributed through the cardiovascular system. They are not associated with exactly the same reactions. And we have really emphasized that the effect, to calculate the effect of the pro-resolving response, is really dependent on the presence of the agonist, but also the presence of the receptors, the distribution of the receptors, and the downstream signaling. And that has been part of our aims, to systematically go through each of the pro-resolving receptors and to try to pinpoint out what are the specific actions linked to a specific signaling pathway from the ligand, receptor, and downstream. And these are the exact things that we need in order to optimize and to know how we can get to, maybe not by one specific targeting, but with grouping different effects and pinpoint down how to make the optimal pro-resolving cardiovascular prevention and treatment.